Welcome to the final video in our Interruption Management course series, Advanced Interruption Management Practices. Congratulations to all of you for making it this far. Today, we're going to put everything we've learned all together, practicing addressing the diverse needs that different types of interruptions have, and really hone in on how you can use interruption management techniques in your everyday practice. Now, while the previous lessons have explained the steps in order, we've yet to lay them out in a comprehensive list. The order of operations, so to speak, of interruption management is as follows, right? We receive the interruption via the interruption queue. We identify the interruption properties. We form a management strategy list, which just means eliminating the bad or impossible strategies. Then, from that list, we select an appropriate management strategy. Then, if that strategy was to interrupt, we select an appropriate recovery strategy. And then, finally, we execute the interruption management and recovery strategies that we've chosen. This full breakdown that you see here is called the interruption management heuristic. And the goal here is for it to become an automatic process, something that you use while not even having to think about it, just like riding a bike or driving a car. Now, let's use this heuristic to go through different kinds of clinical situations. So the first one up is that you are in the middle of pushing an IV medication over a 3-minute period when you hear a patient in the next room scream for help, right? So the interruption cue happens when we hear the patient cry out. This interruption is a very high urgency of around 7 or 8, and it would be very, very tempting to run to the other patient's aid. However, it would be extremely costly to stop in the middle of pushing this medication, right? Stopping now or pushing the medication too fast in your haste to get to your other patient could put the life of your present patient at risk, or at the very least, their health. So the cost is about a 9 or a 10 here. You can't leave what you're doing. And obviously, the two cannot be multitasked. 2 different patients, 2 different rooms. So because urgency and cost are both high, our options here are to either delegate or negotiate. Delegating would obviously be best, so you can do your best to make sure that someone else has the situation under control without leaving your room. However, we have a little bit of nuance here because you actually can't leave your room or stop what you're doing because the cost of interruption is so high. So the most you can do here is likely just to look out your door and see if you can catch anyone. If you can, that's great. But if you can't, then you're going to have to default to negotiating and finish pushing the IV before leaving to check on the other patient. Now, in this situation, we only delegate or negotiate. So you may think that no recovery strategy is necessary because the primary task was never interrupted, and this is true, just for the IV push task. However, we may need to understand a bigger picture because even after you finish the IV push, if you attend to the screaming patient after that, you are still interrupting the medication administration process as a whole. So let's look at the bigger picture. Right? So here's a sample IV medication administration process. There are many tasks in this process. There are 6, right? So after pushing, you still need to saline flush the IV port and document the procedure correctly before you can even say that you are actually done with this process. The failure to do either one of these things could result in problems down the line, and both of these things are part of the medication administration process. So thinking about it this way, we can make the distinction between an individual task and a full-on process. Okay? Now, a task is defined as a singular piece of work that is to be done or undertaken, and this is what we've been referred to up until now when we think about the interrupting task and the primary task. However, it is important to realize that the interrupting and primary tasks can also be complete processes. They can be part of a complete process. And a process is defined as an ordered series of tasks, which is done in order to fulfill an overarching goal. So knowing these two terms, you can now see that it is possible for us to finish a task completely while still being in the middle of a larger process. So if we go back to our example, you just decided to delegate or negotiate depending on what other people were present to assist you at the time. So let's just say, for the sake of this argument, that you're unable to verify a delegate, and so you negotiate. And you decide to finish your IV push before taking any further action. You now have to ask yourself if that IV push is a part of a larger process, which it is, as we've said. So because it's a part of a process, you now need to assess the cost of interrupting the remainder of that process, just as you did with the primary task. So in the case a delegate cannot be found, flushing the IV port and documenting can wait longer than the patient who's crying out for help, right? That total thing, the cost of interruption, is going to be less than the urgency now of the full process. So you do actually need to choose to interrupt the medication administration process at this juncture to go help. Because you choose to interrupt that process, you do actually need to engage in recovery strategies to ensure that you don't forget any of the remaining steps, which would be leaving the port unflushed or incorrectly documenting, and neither of those would be good. So in this case, rehearsal may be enough, but it's always a good idea to try use environmental cues or a checklist if you've prepared one. Always a great idea. So now that we've had the chance to discuss processes, let's take a look at some more examples with our updated understanding. Here's another. You've been providing discharge instructions to a diabetic patient in the ED when the client in bed 2 indicates that they quickly need help to the bathroom. So assuming this second patient requires full assistance, the urgency here is quite high, probably about an 8. Providing discharge instructions is important, but it's not the end of the world if the patient needs to wait a little longer in this case, so the cost is about a 4. And multitasking is not possible. So it's here that we ask if the primary task is a part of a process. In this case, providing discharge instructions counts as an individual task and is likely the last thing that you're doing with this patient. So even if it is part of a process, you don't need to worry about interrupting it. It's the last step. So as the urgency is much higher than the cost, interrupting is a viable option as well as delegating. Deciding which strategy is better here is going to depend on the presence and the availability of other people nearby. So if no one else is around to help, or if everyone around you is engaged with high urgency tasks, then you're going to need to interrupt. If you do interrupt here, you're going to need to engage in a recovery strategy. Rehearsal can work in a pinch, but it's definitely not the most effective. Right, helping a patient to the bathroom with full assistance requires a significant amount of concentration to do so safely. It's going to be much more advantageous to you to use a checklist or to use an environmental cue like a note or an open brochure if your workplace has them, or even ensuring that your patient understands the instructions you've given up until this point. That can work as an environmental cue. Have the patient remind you of where you were when you left off. Any of those are a good idea. So now here's a new example. You're conducting a central line dressing change when you hear alarms going off in the next patient's room. This is another high urgency, high cost situation. The alarms need to be handled as soon as possible, probably an 8 or 9 urgency. But you're not supposed to interrupt a central line dressing change for any reason. 10 costs. You can't. The only thing that you could do is if natural disaster alarms were going on, and even then you'd probably still have to finish this. So, and no multitasking, obviously. It's another thing. Central line dressing change is an individual task that is not part of a larger process, so no concerns there. Given this information, your only available strategy here is going to be to delegate. If no one else is in the immediate area, you're going to have to actively find someone who can handle that emergency alarm situation as quickly as you can. Because you aren't interrupting, no recovery strategies here are necessary. So the proper way to handle this would be to go find someone as quickly as you can to handle those, and then get right back to what you were doing, which is the central line dressing change. But let's say instead of that dressing change, you are instead charting a patient assessment and vital signs of a postpartum patient when those same alarms go off, right? So different primary task. Urgency is going to stay the same, but cost is way lower at about a 5. Sorry, relatedness, you're still at a 1. Cases where multitasking is actually feasible and viable are very few and far between, as you're seeing in these examples. Once again, no larger process is at play here, just the charting task. And although a medication administration process could start as a result of this assessment if you feel that a medication administration is going to be needed. So in this case, your good strategies are either to interrupt or to delegate. Most likely you're going to interrupt because putting that charting task on pause while you attend to the emergency alarms. Because of this, you're going to need to engage in a recovery strategy. Emergency alarms could mean that the patient is in a critical state, which would require a great deal of cognitive effort to take care of. So you can't count on rehearsal alone to help you. You should be using a checklist or an environmental cue, like jotting down a note to yourself about where you left off in the charting process before closing out, or maybe even asking the patient to remind you of where you were. Again, the patient can be an environmental cue. Next, let's address a scenario when one of the most common interruptions in nursing, and oftentimes this is one of the most disruptive, and it's phone calls. So here's the situation. You're calculating doses for a new patient medications when the room's phone begins to ring. The cost of interruption here is going to be about a 5. With focus, drawing up the right doses is not an especially difficult task, but getting it wrong could be disastrous, and interrupting this process increases the risk that you mess up that dose, especially if you're doing it with an unfamiliar patient as you are in this scenario. The urgency of the phone call is therefore going to decide what strategy we choose. But that's the thing. When a phone call happens, you often don't know what it is for. So this call in question could be to inform you of anything between a severely higher urgency interruption of the utmost importance, or it could be no interruption at all. So the problem here is the high level of uncertainty. It's really a probability game every time a phone rings. If you simply choose not to answer the phone, then you could run the risk of ignoring an emergency without knowing it. More technically, because the call has a potential to be high urgency, means that all calls with uncertainty about the subject of that call should be treated as though they are the highest urgency possible, because it could be. It's better to be safe than sorry. Even so, it's also better to be smart than just simply be safe. To be smartly safe than to be blindly safe. If you think about it, it's highly unlikely for someone to call you about something that you're not already involved in while you're helping a patient in their room, right? Why would they bother you with something that you're not involved in? The vast majority of the time, you will be called here about information relating to your current patient or another patient whom you're already in charge of treating. Therefore, you can make predictions about why someone might be calling you. And the urgency of a phone call, given your unique context, if you keep in mind what responsibilities you're currently handling at the moment when you're called. Given these considerations, we can now look back at the example scenario with a bit more clarity. So when the phone begins to ring in the middle of your dose calculation task, you should instantly think of the worst case scenario within reason that could happen to one of your existing patients. If the urgency of that scenario exceeds the cost of interruption for your primary task, then you should answer the phone. However, if it doesn't, it might actually be more beneficial to give the caller a call back after you finish your primary task without interrupting it. Because remember, interrupting is going to give us more error regardless. Even if it's just for a phone call, you have more of a chance if you interrupt. Relatedness here is going to be unknown until you answer the phone in this case, so don't worry about it. Most of the time, your choice is going to likely be to answer the phone. I mean, let's face it. Most of the time, the worst case scenario is in fact quite high urgency. So you're going to want to make sure that you at least use the mental note or rehearsal strategies to help you out with recovery. If and when you do answer a call, you will need to handle any interruptions presented to you just as you normally would. And it might not be an interruption at all. So to summarize, our advanced interruption management skills. Let's have another look here at the interruption management heuristic and plug in the few new nuances and concepts that we've discussed today. So we have, once again, receiving the interruption at the interruption queue. And if it's a phone call, you want to evaluate the worst case phone message that you could get. And you want to identify whether a primary task is the part of a larger process. So whatever you're doing right now, is it a part of a process? Then we're going to identify the interruption properties. If it's a phone call, then the urgency is going to be based on the worst case phone message. And if the primary task is a part of a process, you're going to also evaluate the cost of interruption for the remainder of that process, in addition to your normal properties. Then you want to form a management strategy list by eliminating the bad strategies. After that, you select the appropriate management strategy based on your situation. If you were to interrupt, if that was the management strategy you chose, then you select an appropriate recovery strategy, and then you execute both the management and the recovery strategy. So we've added a couple nuances, but all these things really boil down to concise explanations for common sense principles. At the end of the day, the goal of this entire series is to give you an internalized way of thinking about interruptions that can be applied quickly and effectively with very little effort. Forming automaticity with this process is the most important thing, as it will prevent you from defaulting back to old ways of dealing with interruptions in high stress and high stakes situations. These are exactly the situations in which interruption management is most effective and helpful. So like any skill automaticity, this will come to you with intentional practice and use. So I highly encourage you to use the knowledge that you have gained here as often as possible. The more you make sure to use it, the easier it will become until you don't even need to think about it. Now, I want to thank you so much for making it to the end of this series. You are now a bona fide interruption management expert. Good luck to each and every one of you in your medical journey. Goodbye.